Hello friends, welcome to this session. The whole purpose that we have planned this session is, as you must have appeared in your first pre-test which is there, which is being held, term exam which is being held in your colleges, and most of you must be close to your second term exam like it's in our institution. So it's a bit high time that we understand that our scoring in pharmacology is going to be dependent upon how we perform in our examination. Now, these term examinations and the send-up examinations are one of the key opportunities for us to hone our writing skills and communication skills, because as per the new curriculum, you must have seen that it is the communication which plays a very important role. And earlier, your seniors, those who passed pharmacology or any other subject which was before 2019, so they generally had a practical which just consisted of 25 marks as compared to 100 marks which you have. So this not only gives you more opportunity to get better score, but also use this opportunity to learn and to remember and correlate things better. Similarly, your theory examination now, instead of 40 marks each, is 100 marks each. So again, it gives you more canvas to fill in. This is a sort of you can say a double-edged sword. You have more marks, you also have more opportunity to score, and then definitely it leaves you relatively lesser time, because the time is the same, 3 hours, in which you have to attempt a paper for 100 marks. Earlier, you had to do it for 40 marks. So today in this session, I'll be talking about how to attempt a long answer question, because it is an art how to attempt a long answer question. We'll also talk about how to attempt a short answer question, and then how to demonstrate your communication skills, because that's a very important part in your practical examination. And another thing, how to demonstrate your psychomotor skills. I understand most of your labs must have, most of your departments must have had the labs which are skill labs, and you must be practicing on mannequins, and you must be having some hands-on experience how to communicate with the patient, because this is a simulated situation which you would have in your examinations. I'm trying to use the same setup which has been shared by National Medical Commission regarding the type of questions which is there, and I have gone through a number of question papers all across the country, from which I've tried to derive certain examples, and I'll try to share with you how is the best way to attempt these questions. Now, this is for a long essay type question. Now, please don't get afraid or demoralized, what is this thing? So it is basically a long answer question. Now, there is a provision that it could be a scenario based. Now, remember, since 2019 batch, there are a lot of changes which has happened in the curriculum, and now the questions are no longer straight questions. You might have a scenario over here. So I have tried to pick up a scenario which appeared in one of the university exams somewhere in the country. And you need to understand that when you get this question paper, you need to spend first 5 minutes reading all the questions. There's no hurry. Understand there are 3 hours which you have, in which you have to attempt the whole of the question paper for 100 marks. You just need to just read the question paper. Sometimes it happens that when you're reading the questions, sometimes some hints are given in some other questions which have been inadvertently added up, because there are so many actions, because a drug could be having an autonomic effect, it could be having a cardiovascular effect, it could be having some effect on endocrinology, and therefore it is being asked as a part of endocrinology or as a part of cardiovascular system. It might give a hint to a drug interaction, a contraindication, a therapeutic use, or the status of that particular drug. So it will help you to remember it. And another thing which I always tell my students is that whenever you have this question paper, you have the last page of your answer sheet. So you can write or scribble on that answer sheet. So this ensures that if your examiners or the evaluators who are there, they cannot say that it is a case of unfair means, because you have the answer sheet which is lying with you. I generally do not recommend writing anything on the question paper other than your roll number, because sometimes it might slip somewhere and it might be in somebody else's hand, and it might be accused of using unfair means. So it's always better to use your own answer sheet and scribble the small points which are there. And when you're going to attempt that answer, you should be able to make points from that. Now, I'll just read out the first question. A 3-year-old girl presented to the emergency with history of 3 vomiting episodes. following which she was taken to a local doctor who administered an injection. The vomiting stopped, but 2 hours later, she developed these manifestations as making bizarre faces, head tilted to the right side, her teeth were clenched, and she was not speaking. The eyes were staring in one direction, and there was intermittent, purposeless movement of upper lips. Now, what is clear up till now is that this is a child who had episodes of vomiting, who received some treatment, and following the treatment, the patient had these manifestations. Now, it's important to remember that you must have a sense of clinical diagnosis. One might think that, okay, if there is a purposeless movement, there is a staring, there is clinching, the child is not responding, it might be epilepsy. But it is not epilepsy because there are manifestations which have occurred in form of there is a bizarre face, and it is a continued process. Once a person is having epilepsy, the epilepsy episode generally does not last more than 50 seconds to 1 minute. But until and unless it goes into a status epilepticus, then it definitely can have a longer period of time. So it just seems like that these are the manifestations of extrapyramidal system stimulation. So the questions are, which group of drugs could have led to these manifestations? Classify these agents and illustrate the site of action of these drugs. Why did she develop these manifestations? And lastly, which group of drugs can be used to reverse these manifestations and how would they be effective? Up till some time now, we used to have questions which are clinically oriented or a scenario-based question. And there is a possibility based upon the university that you are appearing in, they might not give a probable diagnosis. But here, for the sake of convenience, we have given a probable diagnosis that these are extrapyramidal manifestations. Now, it can happen that it could be mentioned over here, name some antiemetics or classify antiemetics. Because if you remember, as the scenario is presenting itself, it is a young child who had vomiting episodes and required some treatments. Obviously, if there is a vomiting episode, it must have been an antiemetic which has been given. Now think of those antiemetics which can cause extrapyramidal manifestations. The extrapyramidal manifestations will occur because of stimulation of D2 receptors. So those antiemetics which are having D2 antagonism, they are the ones which will cause manifestations of extrapyramidal system stimulation. As you can see, it's just taken a few images. You can see there is a torticollis. The child has bended neck on one side. It is staring over there. There are no other manifestations which are there. So if you have to write it over here, because this is containing for 2 marks, so you can write that it is because of D2 antagonism that there are these manifestations of extrapyramidal system. The second question is classify these agents and then demonstrate the site of action of these drugs. If you saw in the introductory session earlier, I had talked about that whenever you're going to talk about classification, you must talk about how this is being classified. Now, we can classify these drugs as the site of action. Now, these could include anticholinergics. So, example, you have to give at least one example every time you write a drug. So, these include hyoscine or dicyclone. It could be having H1 antihistaminic activity, which could be contributing to antiemetic effect. And here we have promethazine, dimenhydrin. It could have D2 antagonism, which is seen with chlorpromazine. It could also be prokinetic. As the name indicates, they're going to increase the motility. This includes metoclopramide. This drug, metoclopramide, also has D2 antagonistic activity. So it could be also, so it could either be chlorpromazine, it could either be metoclopramide, which has been given to this child, which resulted in these manifestations. Then we have serotonergic 5-HT3 antagonists like ondansetron. Then we have neurokinin 1 receptor antagonist like apritat. Then we have cannabinoids like dronabinol. And lastly, we have adjuvant emetics, which actually do have antiemetic effect. For example, dexamethasone and benzodiazepine. So from this, you can understand that there are going to be different receptors which are going to be acting. Now, this is one example which you can look at. So this is depicting how vomiting happens. Obviously, vomiting is going to happen with the stimulation of the vomiting center. Vomiting center could be stimulated by activity on the inner ear, which could be seen in neuritis. And the action would be mediated through muscarinic receptors and histaminergic receptors. It could be through GIT stimulation at the stomach or small intestine, could happen in patients who are undergoing radiotherapy or those who have colitis. And these actions are mediated through serotonergic, that is 5-HT3 receptors, dopaminergic receptors, and muscarinic receptors. It could also happen through higher cortical centers. It could be because of increase in intracranial pressure. It could be because of anticipation. It could be because of a smell. It could be because of a memory linked with a particular situation or a food. It could be because of anxiety. And the mechanisms which contribute to stimulation of this vomiting center are GABA and histaminergic receptors. Lastly, it could be by the stimulation of chemotactic trigger zone, which is outside the blood-brain barrier. It could be by drugs like opiates. It could be because of hypercalcemia, or could also be because of cancer chemotherapy. Cancer chemotherapy could also be producing vomiting by stimulating vomiting center through chemotactic trigger zone stimulation, or also through stimulation of the GI impulses. So here the receptors involved are neurokinin 1 receptors, dopaminergic receptors, cannabinoid receptors, and serotonergic receptors. Now we already have talked about the various drugs that we have put according to their site of action. And if we place them on this diagram, okay, so it could be populated. If you look at those drugs which are acting at CTZ, so these include neurokinin 1 antagonist, these include dopaminergic antagonist, this include cannabinoids, it includes ondansetron, which is a 5-HT3 antagonist. It could also involve drugs which are acting through higher cortical centers, that is antihistaminics, and GABAergic drugs like benzodiazepine, drugs which are acting through inner ear, that is anticholinergics and antihistaminics, and drugs which are acting through GIT impulses, that is dopaminergic type 2 antagonist, anticholinergics, and serotonergic 5-HT3 antagonist. So this is one diagram which can very easily you can draw, and this can depict all the drugs which are there. It's easy for you to remember. You can look at the various neurotransmitters, various mechanisms which are responsible for stimulation of the vomiting center, which is resulting in vomiting, and consequently, you can very easily label your diagram with the site of action. So this is a simplified version in which you can attempt this. If you want to get more score, you can make a diagram which is, or you can make a diagram of a cerebellum or a brain at higher cortical centers. CTZ, you can put brainstem area. In GIT and stomach, you can draw an outline of a diagram showing stomach, and inner ear, you can simply show the inner canal. So again, this would add up more image or more quality to this diagram. And this will help you to demonstrate the site of action of these drugs. Now, coming on to the third part of the question, one thing more, the dexamethasone. It is also effective in lowering intracranial pressure. It is also used as an adjuvant in number of other chemotherapies to have an additional effect as antiemetic. Now, why did she develop these manifestations? As I said in the beginning, that this child had vomiting and received an antiemetic, following which these manifestations occurred. These manifestations occurred as extrapyramidal manifestations, and the ones which have been described, they are called as dystonias. They are manifesting as acute dystonic reactions and tolerance. So there could be oromandibular dystonias, which affect the lower facial and the jaw muscles, causing involuntary opening, closing, or deviation of the jaw, and the tongue may also be involved. It could be cervical dystonia, in which the neck muscles, it could be having abnormal movement and there could be just deviation to one side. Or it could be limb dystonias, in which there are involuntary movements, cramping, spasming of legs and feet. So therefore, this needs to be differentiated from epilepsy. So in acute dystonia, there is a face grimacing, there is involuntary upward eye movement, there are muscle spasms of tongue, face, neck, back, one side, and there could even be laryngeal spasms. Remember, these manifestations occur more commonly in children due to stimulation of dopaminergic receptors, and especially once there is a parenteral administration. So one must always look at if you have a child or an elderly, because more prone are extremes of age. If you have a child or elderly person who is presenting with these manifestations, and the onset may occur within days to even few hours, like it happened within 2 to 3 hours of this administration in this child. Now, coming on to which group of drugs can reverse these manifestations and how would these be effective? As I mentioned, that this is a manifestation of a system which is dopaminergic antagonist producing this effect. So here we use anticholinergic medications which are blocking acetylcholine, which balances dopaminergic activity. You are right. This is what is going to happen in the extrapyramidal symptom. Remember, there's a delicate balance between dopamine and acetylcholine. So if there is dopamine antagonism, it can only be covered if we are going to counteract the acetylcholine activity, which has now increased as there is decrease in dopaminergic activity. So therefore, we are going to use drugs which are having anticholinergic activity like diphenhydramine or chlorpheniramine. So drugs with having anticholinergic medication, they are the ones which need to be used. Important thing to remember at this point of time is that these manifestations occurred because of the imbalance. This patient is not having any extrapyramidal manifestations because of underlying disease or pathology. This just happened because the balance got mismanaged by administration of a drug which blocked dopaminergic receptors, and hence it resulted in this effect. Now, coming on to the second type of question, it is a short note. Now, in this paper, you would have questions which are long questions, like I mentioned. This is a 12 marks question. You could have short questions which could be having 6 marks, 3 marks, 4 marks, depending upon your university regulations which is there. So short notes, they have to give a wider content. This has to be covered within a short period of time. And for pharmacology, let's say we are covering another topic, that is writing a short note on phenytoin. As I mentioned earlier, whenever you're going to get a short note, remember you have to write all that you know about phenytoin. So as you saw in that introduction video, so we are going to cover 10 points whenever we're going to talk about phenytoin. You remember what is a phenytoin? Phenytoin is a drug which is an anti-epileptic. It belongs to hydantoin chemical group. And look at the mechanism of action. Now remember, this is what is representing inhibitory neurotransmission, which is being through GABAergic neurons, and this is an excitatory neurotransmission, which is through glutamate. Remember, they are going to be interneurons, they are going to be relaying on one another, and hence they would be having these effects. Classically, phenytoin is a drug which acts by causing sodium channel inactivation. So meaning thereby, if there is sodium channel inactivation, there's an action potential coming from higher up, it will not pass down. If it does not pass down, it means it will not cause further release of neurotransmitter. For example, the neurotransmitter which will increase neuronal activity, that is an excitatory neurotransmitter, that is glutamate, and it will inhibit the neurotransmission activity in case it is releasing inhibitory neurotransmitter, that is GABA. So this causes a sodium channel inactivation which is prolonged, and as a result of which it is able to inhibit the passage of excitatory or stimulation which is happening in the higher neurons to the subsequent. At higher dose, it also facilitates GABA. So obviously, number one, as the neuronal activity is not passing down, it is getting blocked. So therefore, there is no further activity which is going to happen, which will translate from neural activity into a physical activity. It is facilitating GABA, which is an inhibitory neurotransmitter, which will further reduce. But again, this is a fact which is seen at higher doses. It also decreases glutamate release, which is another excitatory neurotransmitter. And obviously, when we decrease excitatory neurotransmission, again, it decreases the activity which would be happening in these neurons. We have covered what is the type of action which the drug has. We have covered what is the chemical nature. We are talking about what is the mechanism of action. Now coming next to what is the pharmacological action. So obviously it's an anti-epileptic drug. So its pharmacological action is that it is an anti-epileptic drug. When you look at the pharmacokinetics, now remember it is a drug which is being used orally. For epilepsy, it has to be used for a longer period of time. So it is a drug which is well absorbed. It is a drug which is undergoing metabolism in the liver by two set of enzymes, CYP2C9 and CYP2C19, and it undergoes metabolism by having glucuronidation. It's a drug which is classically known for producing zero-order kinetics at higher dose, meaning thereby, as we increase the dose, its elimination increases, but when it crosses a particular dose, when the enzyme is fully saturated over here, the dose kinetics shift from proportionate to fixed amount, which is getting eliminated, resulting in a toxicity manifestation. It has a high plasmapheresis binding, which could cause a number of problems. It is also contributing to its longer half-life, and it is also a microsomal enzyme inducer. Now, these are important things to remember when we are talking about high plasmapheresis binding, when we are talking about microsomal enzyme inducer. Remember, they would have an impact on drug interactions, which again need to talk about when we are writing a note on phenytoin. Then coming on adverse drug reactions. So phenytoin is notorious for causing hypersensitivity reactions. It could be as simple as a rash, or it could be as severe as Stevens-Johnson syndrome, which also could be fatal. Remember, it's a drug which is going to cause effects on the CNS. It causes inhibition to a certain extent. It can cause nystagmus, vertigo. It also is notorious for causing gum hyperplasia. This is a very important point. You can get short notes. You can get MCQs on this area. It causes hirsutism. So it's not a preferred drug for women. So you can look, a lady who is on phenytoin has a risk of gum hyperplasia, hirsutism, which would just not be very acceptable. So again, this makes a point that you can write over there that when we look at important precautions, it is not to be used very commonly or preferred by female gender. If given in pregnancy, causes a fetal hydantoin syndrome, in which there is septal defects, there is microcephaly, and it would also result in osteoporosis. Now coming on to the uses. As it's an anti-epileptic drug, it is used as a drug of choice in generalized tonic-clonic seizures and partial seizures. It's a preferred drug. As I said, if you look at the ADRs, it carries a risk of producing nystagmus, vertigo, gum hyperplasia, hirsutism, fetal hydantoin syndrome, and obviously it's going to be used for a long period of time, also carries a risk of producing osteoporosis. So it is preferred, but it is not the drug of choice. So depending if it's a male, we can still use it because these effects would not be a major cosmetic effect on males. It can also be used in partial seizures. Then we also have to look at cost considerations which are there. It is a drug of choice which is used in status epilepticus after the first drug, that is benzodiazepine, which is these days lorazepam, which is preferred over diazepam, and immediately after that we have to use phenytoin over here because it has a very good bioavailability to get rapidly, causes increase in the plasma concentration and produces the anti-epileptic effect very fast. It can also be used in trigeminal neuralgia, but the drug of choice is carbamazepine. So here, when we are discussing about therapeutic uses, we're also talking about their therapeutic status. The next thing we need to talk about is contraindication. Obviously, as this drug is having a higher episode of allergic reactions, so obviously it's a contraindicated if there is hypersensitivity reactions. Then drug interactions, we talked about this drug, it causes microsomal enzyme induction. Therefore, another antiepileptic like carbamazepine and phenytoin, if used together, they induce each other's metabolism, resulting in need for increasing or stepping up the dose. Valproate is another antiepileptic which displaces protein-bound phenytoin because it is also having high plasmapheresis binding. It also decreases its metabolism, as a result of which the phenytoin plasma concentration rises. Now, this is a very important thing to remember. Remember, this is a drug which has a possibility of shifting of kinetics from first order to zero order. So as the plasma concentration rises, because there is an increase in the free drug concentration, therefore there is a chance that it might shift from first order kinetics to zero order kinetics. Then isoniazid and warfarin, they inhibit phenytoin metabolism and can cause toxin. Remember, isoniazid is an important drug which is used in patients with tuberculosis. Similarly, phenytoin also competitively inhibits warfarin metabolism. It also induces microsomal enzymes. So it's a very important thing to remember. Therefore, it increases degradation of steroid and therefore causes a risk of oral contraceptive failure. So this brings us to the next point, that is precautions. So obviously, it needs to be avoided in ladies who are planning a pregnancy. Now, please remember, when you have a lady who is coming with a reproductive age group, who is planning a family, so one must not start with phenytoin as an anti-epileptic drug, though it might be one of the options which are available. Try to use some of it. Then if the lady is in the if the lady is married and wants to use a hormonal contraceptive, we do not recommend to use hormonal contraceptives. Obviously, if the mother is or if the lady is not nulliparous, then you can use IUCD, or you will have to use advice use of some other contraceptive method which is non-hormonal, because whichever hormone you're going to use, it is going to have increase in the metabolism resulting in contraceptive failure. And another important thing to remember is phenytoin is never to be given as intramuscular. It can be given as oral, it can be given as intravenous, but never as intramuscular, causes muscle necrosis. If you have to use a water-soluble formulation, that is phosphate. Now see what we have talked over here with an example, that if you get a short note of phenytoin, we talk of basically how this drug, what is its major indication? It's an anti-epileptic drug. Then what is its chemical nature? It's a hydantoin. What are its mechanism of action? It acts by inhibiting sodium channel or prolonging sodium channel inactivation. That is the main action, but at higher doses, it also has a kappa mimetic action and decreases the glutamate release. Then you look at the pharmacological action. It's an anti-epileptic drug. You look at the ADRs, you look at the pharmacokinetics. It is a drug which is given orally, having a high plasma protein binding. It is having microsomal enzyme metabolism by CYP2C9 and 19. It can cause microsomal enzyme induction. It is a drug which follows first order kinetics, but at higher doses, the kinetics shift from first order to zero order. Then looking at the ADRs, there's a wide range of ADRs that we have looked at. It could include hypersensitivity reactions. It could include CNS effects in the form of vertigo, nystagmus. It could be causing osteoporosis, could cause fetal hydantoin syndrome, can cause hirsutism, can cause gum hyperplasia. And the important thing to remember is we talk about these drug interactions, which can happen because of its properties of microsomal induction, because it's metabolized by microsomal enzymes. So inhibition of microsomal enzyme, high plasma protein binding can cause displacement reactions. Then coming on to therapeutic uses, it's mainly used as one of the preferred drugs in patients having generalized tonic-clonic seizures, partial seizures. It can also be used, or it is used as one of the main drug after using benzodiazepines, that is lorazepam. We use phenytoin, and these days we also can use phosphenitoin. And important precautions to be remembered is it is avoided to be in patient ladies who are planning pregnancy, ladies who are using oral contraceptives or hormonal contraceptives, and it is never to be given as intramuscular injection. I hope this point is clear about how we are going to write about a note. Obviously, I'm just giving you points. This needs to be translated into sentences which are there, and depending upon the time you have, you need to cover these points. You can also add up or supplement. I've given you a small diagram which you can easily draw over there and which can help you get better score. Then there could be reasoning questions. Reasoning questions, these are an opportunity for testing integration. So one of the very common question which is asked in examination, even in Viva, is why adrenaline is the preferred medication in anaphylactic shock. We'll just try to enumerate the various causes. So adrenal anaphylactic shock, we all understand, it is a severe form of life-threatening allergy. So when you're going to start such a question, though it's having 3 marks, it's always better to write a sentence or two about the disease, about the topic that you're talking about. It's a life-threatening allergic reaction. So you can talk briefly about manifestations, causes swelling of mouth, tongue, breathing problems, flushing, collapse, and loss of consciousness. So once you have briefly talked about it, bring forth what are the problems that you're forcing. So obviously there's a problem in which there is fall in blood pressure, as it is a shock. It is occurring because of release of histamine, because of anaphylaxis. So therefore, there is going to be bronchospasm. There's going to be fall in the blood pressure. And therefore, we try to attempt it over here that we can use adrenaline because of the following reasons. Number one, remember, epinephrine is the physiological antagonist of histamine. So by being physiological antagonist, it is going to reverse all the effects that are being produced by histamine. But remember, already this reaction has happened. So just reversing the actions would not be good enough for the treatment. What we need to reverse the changes which have happened. So remember, epinephrine is a drug which is acting through alpha 1, alpha 2, beta 1 and beta 2. All these are going to contribute to its role in patients with anaphylactic shock. Beta 1 is a cardiac stimulant because it is merely predominantly present of the heart. It causes increase in the heart rate, increases force of contraction, which will increase the blood pressure. We have alpha 1 activity, which is again a vasoconstrictor activity, which increases total peripheral resistance. There is vasoconstriction, which causes increase in the blood pressure. So increase in heart rate, increase in force of contraction, increase in the blood pressure is helpful. In addition to this, there is a vasoconstrictor action. Remember, this vasoconstriction action is going to reduce the mucosal edema which is there. Remember, we talked about there is swelling in the mouth and the tongue, which is going to be reduced by this vasoconstrictor action. Therefore, it will improve the air entry which is there. And in addition to this, remember, it also has a beta 2 stimulant effect, which is bronchodilatory effect, which causes decrease in the release of mast cells mediators, which is further propagating this reaction. We generally use adrenaline in the dose of 0.3 to 0.5 ml in the concentration of 1:1000, which could be also diluted, but it can be given by intramuscular route, can be given by subcutaneous route. This all could be helpful in the patient to recover from anaphylactic shock. Remember, epinephrine is the drug of choice for anaphylactic shock. Simply remember, it's a physiological antagonist of histamine. It is having beta 1 activity, alpha 1 activity, and beta 2 activity, which is all contributing to reversing all the manifestations of anaphylactic shock. So remember, you already know about anaphylactic shock from your pathology. You can use this information from pathology to have a build up about it. Remember what are the pathophysiological changes which are happening, and then try to use drug which is going to reverse those changes. That will help you to enumerate in a better way. Now coming on to another example, this is about short notes on the applied aspect. We are talking about the clinical significance of half-life of a drug. So again, this is a 5 marks question. So it is very important that when you're going to talk about half-life. So what is half-life? You can first put a definition. Half-life is the time which is required for plasma concentration to fall by 50% of its initial value. You can supplement by your answer by putting or making a log plasma CP versus time graph in which you can show that the time which is being taken for fall in the plasma concentration. And remember, when you're going to make it, because this is a drug, if you're depicting is to be following a first order kinetics, there should be equal fall for the same period, because for each one half-life, the concentration has to fall from 50%. So it must take the same time to fall from 100 microgram per ml to 50 microgram per ml, and then from 50 microgram to 25 microgram per ml, and then from 25 to 12.5, and then from 12.5 to 6.25. It should take the same period. This is fixed in case there is a first order, and it is variable in case there is a zero order kinetics, and it is calculated as inverse of 0.693 over k. You already have done in your classes that why it is constant or why this is over there. The product of half-life and k is always going to be 0.693. So if you know the half-life, you can calculate k. If you know k, you can calculate the half-life of a drug. It is an important pharmacokinetic parameter. It is used to determine duration of action. Once you know the half-life of a drug, you can plan that what is going to be the frequency of administration for this particular drug. And it takes around 4 to 6 half-lives to reach a steady state concentration. And then you can depict or you can plan out how much time it will take to reach that concentration. Once you know the half-life, you can calculate the dosing interval. Obviously, half-life would be only for the parent drug. A drug could have a longer duration of action in case there is an active metabolite which could be contributing to further extension of the pharmacological actions. You can also use it to calculate loading dose and maintenance dose. It is also useful for looking at the various phases of drug. Sometimes you have two different half-lives. It is half-life alpha and half-life beta. So you can have a diagram in which you can have two different slopes. Half-life alpha could be because of redistribution as well as elimination and the metabolism which is taking place over here. And half-life beta could be following only metabolism and elimination taking place, which is there. And you will have two different slopes which are depicted in your diagram. Then to calculate, it is also used to calculate Ke. As I told, it's a constant. That is, if you multiply Ke and half-life, it's always going to become 0.693. This already has been explained in the various lectures that we have delivered on DigiNerve for talking about this particular topic, that is pharmacokinetic parameters. So it can also be used to calculate Ke. And remember, it's an important thing that half-life of the drug, it is also useful for therapeutic drug monitoring. So here you can write about that if you know the half-life of a drug, you can depict or you can plan what time to take a drug sample. Because you know the half-life, you want to have a trough concentration. That is the lowest concentration that you will take just before the last dose, just before the next dose that you're going to give. If you're going to look at the toxicity, you must like to find out what is the highest concentration. That you will take somewhere which is mid between the two doses. So that would be the peak concentration which is there. So if you're just trying to detect whether the person is taking drug at all, you can just take a sample at any point of time. So by knowing the half-life of a drug, so we can find out what is the duration of action, what is the time to achieve steady state concentration, what is the dosing interval which is going to be there, and then you can also use it to calculate loading dose, maintenance dose, what are the various phases of drug elimination. You can calculate K, and also for making planning for the therapeutic drug monitoring for a particular drug. It's a very important parameter that you must always know. Then these days it is mandated that you would have also one question on ATCOM. Like in our university, we have the different components of ATCOM, that is from 2.1 onwards. So we have allocated one ATCOM unit only to one paper. So paper A and paper B in pharmacology would have only one ATCOM unit. So students don't have to read whole of the ATCOM units for each paper. So this could be that define autonomy, explained by giving a suitable example. So autonomy is the choice which a person has to take a treatment or not to take a treatment. So I will not develop on it because it's not directly related to pharmacology. But remember, you would have at least 5 marks question each of your theory papers on ATCOM. And this is another example, like in our university, we have 20% of questions which are multiple choice. If you see over here, again, this is a long question, which is again a scenario based. A 25-year-old lady was using oral contraceptive for the last 2 years. She got tuberculosis, was prescribed rifampicin. She became pregnant after 2 months of starting rifampicin, despite continuing oral contraceptive. Which of the following effects of rifampicin can be the reason for this? So obviously, the given scenarios, we all know that rifampicin is a microsomal enzyme inducer, like we talked about. Also, phenytoin, which is also microsomal enzyme inducer. So therefore, the answer is there is induction of oral contraceptive metabolism, which is resulting in failure of contraception, and hence this lady became pregnant despite using oral contraceptives. Now, with this, I've tried to finish up with how to attempt a long answer question. I've tried to give you a very wide spectrum of various short answer questions, which could be about explanation, which could be about a short note, which could be talking about the clinical significance of the various parameters which is there. Now, coming on to the practical component. So when we have the practical component, remember there are going to be different things which are going to be evaluated. Now, one of the exercises which is being put up at most of the places is ADR reporting. Now, ADR reporting, I'm trying to give you a scenario. I'll just read through it. This is a 55-year-old female. We have given a name. We have given body weight. Who came to the hospital with complaints of cough, throat pain for the last 4 days. She was diagnosed with upper respiratory infection. On this particular date, a general physical examination showed that she was healthy, well-oriented, time, place, and person. There was nothing abnormal in her general physical examination, no jaundice, GVP was normal, vitals were stable, with heart rate of 72, respiratory rate of 16. She was having a temperature of 38 with a blood pressure of 120 by 80 millimeter mercury. Her systemic examination was normal. There is no significant past history. On lab investigations, the hemoglobin was 12 grams per cent and TLC was 15,000 per cubic millimeter. She was advised the following treatment. So it means she had fever, she had some infection. So she was prescribed an antibiotic, that's a cotrimoxazole, and another analgesic, that's ibuprofen. We've written the frequency and we have written the batch and expiry. Then on the very next day, she complained of maculopapular rash and itching all over the body. She was asked to stop the treatment. She was prescribed the following treatment and report after 1 week. So therefore, we have changed here from cotrimoxazole and ibuprofen. We have shifted the patient to azithromycin and cetirizine. And after 1 week, the patient was better and the rashes had disappeared and there was no. Now here we have given you a scenario in which you will have a time according to your university guideline in which you'll have to fill up the form. First thing to remember is when you have this scenario, you have to first really underline what are the important things. What are the important things that you are going to fill up in the ADR form? Remember, the current version of ADR reporting form is 1.4. So if you see over here, this is an initial case, because if you're reporting it now, or it could be a follow-up case. So you have to put the patient initials, you have to put the age, which is already given, weight we have already given, gender we have mentioned. Then about the event and the reaction started. It started the next day, so date is given, 20th, brief description of the event over here, the medications which have been given, what was the action taken, it was the drug was withdrawn, then whether the reaction reappeared, so it did not reappear over here, and what are the concomitant medications which the patient received, and what are the initial investigations, so they should put value over here, what are the relevant investigations, the TLC that we have given. Okay, is there any relevant history? There's none. It is not serious because it did not result in death. It was not life-threatening, did not require hospitalization, did not result in a congenital anomaly or a disability, and the outcome was the patient has recovered. And the important thing is you have to give your own details because you will report your. Obviously, each university would have a different way to do it, but you must have a practice of filling up this form because this will help you to attempt your exams better. Another common thing which is asked in practical is you are to evaluate a given prescription. So you're given a prescription over here. So you look at the patient identifiers, you look at the chief complaints, you look at the history of allergy, examination, and you look at what is the treatment which is being taken. So here you have a patient who has been diagnosed with diarrhea. You see over here the patient is prescribed an ORS sachet, given syrup zinc, tab syrup dolo, and they've given another lactobacillus preparation, which is there. Now you need to identify what are the errors and you have to correct. What are the errors over here? You find diagnosis given, patient details are given over here, but what is wrong? You need to know that there is use of abbreviations, OD, SOS. So patient is not expected to know these abbreviations. So you have given nothing as a non-pharmacological treatment. ORS you're giving as a pharmacological treatment, but you need to talk them about substitutes for ORS in the form of coconut water, rice water, and giving some patients some light food, which is there. Then there is nothing about directions to use. You have just written OD and duration, which is given over here. You have used abbreviations which are not accepted. And again, remember, you have to give the generic name. Dolo is the brand name. Though for the Darolac, they've given the generic which is there. So it should be that this Bacillus subtilis, it should come here, and the Darolac should come within the parenthesis or bracket. And similarly, paracetamol should come in instead of Dolo, and the Dolo or the brand name can come in brackets over. So this is one way to look at the various prescriptions over. So already they have given a history of allergy, though obviously it's a diarrhea. It is not mandatory that every patient of diarrhea requires an antibiotic. So if you write antibiotic is required, it might be a wrong thing. You have to stick with what has been given. It is a 1-year-old child. It could be only a rotavirus diarrhea which the patient has. So again, this is very important. Don't try to overact and go beyond what is there. You have to look at what is given, whether it's appropriate or not. Then coming on to the third important part, that is about communication skills and psychomotor. Remember, you all have seen the competency document. The competency document which relates to practical examination is looking to demonstrate empathy, demonstrate ethics, demonstrate about the storage of various dosage forms, compliance, the cost of the treatment, proper use of medication, optimal use of drug devices, motivation for adherence to therapy, especially with chronic diseases, ethical and legal aspect of medication, drug dependence, and use. Now, I'll try to give you a scenario in which we are going to check the communication skills. Now, see, this is a scenario which is coming up. A patient with history of bronchial asthma has presented to the doctor. He has been prescribed combined salmeterol and fluticasone meter dose inhaler. Demonstrate how would you communicate with the patient regarding the use of this form. So obviously, what the scenario you can see over here, there might be a volunteer who's sitting, who is going to mimic as if this patient, and there would be different dosage forms available. For example, there would be insulin pen, there would be meter dose inhaler, there might be a spacer, there might be ORS packet, there might be an insulin pen. And first thing you have to find out that which is a meter dose inhaler. And then you have to communicate with the patient. Now, when you want to communicate with the patient, remember the competencies that you have to use. The competencies that you have to use it, you have to be empathic. You have to demonstrate your ethics. You have to talk to the patient about storage of this device, about the compliance to the treatment. Because obviously asthma is going to require treatment for a longer period of time. What is the cost of the treatment? How to use this proper dosage form? How to use this drug? You motivate them for adherence to therapy. What are the ethical and legal aspects of medication? Is there a risk of drug dependence or OTC? For example, one of the things which can be asked is to apply a transdermal patch. So transdermal patch would be opioid. So if it is an opiate, then you have to talk about drug dependence and OTC. Now this is a scoring system that has been developed. So it takes into consideration all the competencies that you talk about. When you greet the patient, you are talking about with empathy to the patient. You're talking about ethics to the patient. You're going to explain the diagnosis. You're going to explain the treatment option. There's oral drug which you can use. You can also use a transdermal preparation which is there. You can use a inhaler which is there. And obviously, these treatment options entail different costs. So when you're going to use an inhaler, the cost is going to be higher. But the important thing is the dose that you're going to be delivering is much less. So then, remember, this is a drug which is containing corticosteroid. They have to explain them, to rinse them out before taking the inhaler. Then steps to use the inhaler: remove the cap, hold the inhaler upright, shake it well, breathe out, and then place the mouthpiece in the mouth, close your lips, and start inhaling the moment you start pressing it. Hold your breath for 10 seconds and then remove the inhaler, breathe away, replace the cap, repeat the steps if second dose is required. After waiting for 1 minute, then again rinse them out. Explain about compliance of therapy, that one needs to use it regularly. Explain the ADRs, that it could be causing bronchospasm because you're using inhaled preparation. It could cause tremors. Explain the food to be avoided, that we should not try to take too much of spicy food, any food which causes allergy, which causes these episodes to happen again. Explain the storage of device, that this has to be placed in a cold space, in a cool place. You don't have to place it in a fridge. You don't have to place anywhere else. Remember, this is containing a canister, which is having a compressed drug in it, and dispose it. It can be disposed of very simply in the waste. Okay. So this is a very important thing to remember, that whenever you're going to communicate this, remember the points that you need to talk about, the points that you need to demonstrate. They include empathy. They include your using of ethics by being considerate to the patient, explaining them the cost of the treatment, the various treatment options, what are the various adverse effects which is there, how to use it, what are the important precautions, how to ensure that you are going to have a better response if you want to be compliant to the treatment, also how to dispose of this drug so that you do not add on to the biomedical waste for this particular preparation. So coming on to the last example, that is to demonstrate the administration of a provided drug through intravenous route on a mannequin. So obviously, the NMC now has mandated that you have to have a skill lab where you're going to use mannequins to demonstrate these routes of administration. So what are the important aspects that you're going to be looking at, which are going to be evaluated by your examiner? So you're going to talk about ethics, how to store it, proper use of medication, optimal use of drug devices, and ethical and legal aspects of medication. Now remember, you are going to use an IV route of administration. So obviously, it is ethical that you're going to always use a fresh syringe. Okay, you're going to wash your hands, you're going to wear gloves with the proper technique, uncover the arm completely, give support to the arm, apply a tourniquet, and look for a suitable vein, disinfect it, clean the area with a swab, allow it to dry, remove the syringe and needle from the pack, fill the drug in the syringe, check it for air bubbles, remove if present, stabilize the vein by making it taut, and then you introduce at 45 degrees, up to 45 degrees, puncture it, move it slightly, hold the syringe and the needle steadily, aspirate if blood appears, then hold the syringe steadily. If it does not, try again, loosen the tourniquet and then inject very slowly. Withdraw the needle swiftly, press the sterile cotton onto the opening and secure with adhesive. Now, if you see over here, not all the steps which are there, they have been given a score, because these are not actual the steps which are about IV injection, but they are important. They have to be performed. So if you're not washing your hands, you're not wearing gloves, you're not uncovering the arm, and simply you're just jabbing the needle over there, it is not going to administer. You will not get that thing. Because this is a process which is involving only the skill of giving IV injection. There are steps which are before it, there are steps which are after it, and then you have to dispose of the gloves, you have to destroy the needle in the needle destroyer, wash your hands, and this is how this is going to be. So if you see, I have tried to give you an example in which I have tried to tell you that how an examiner is going to evaluate on various components which are there. And this is a good way to understand how your competencies are going to be evaluated, how you're going to be trained over there. So use this opportunity to learn all these steps, to practice over there, so that once an exercise comes to you, you are able to perform flawlessly. It could be as simple as giving a subcutaneous injection, giving an intramuscular injection. So again, depending upon the institution that you're working in, depending upon what are the exercises you're being given, you'll be given a whole mannequin or simple single arm over there. So whatever is provided to you, where you are practicing, please use this opportunity to perform well. So at the end, I'll like to give you some tips. Remember, about when we talk about theory examination, first read the question paper very carefully. As I said, in my university, we have 20 MCQs. So obviously there are 30 minutes which are separate for them. They are going to be attempted, they're going to be taken off. So it means you're going to be left with another 2.5 hours in which you have to read the whole of it. So obviously, as you have read or you have tried to attempt the MCQs, there might be some hints onto, or there could be something additional information which might strike a chord with you, and you might be able to recall things which are being asked in the rest of the question paper. Plan your answer. As I said, that once you have read it, take the last page of your answer sheet, scribble question number 1A, 2A, 3A, so on and so forth. And these are the points which come to your mind. And when you're going to attempt it, please always try to attempt it in the same sequence. Question 1, all the parts should be done. You should not try to attempt the questions like question 1A is done at 1, then it is followed by question 2B, then it is followed by question 3A, then it is followed by question 1B, and then it is followed by 1C. Not like that. You should always try to attempt them in a sequence. If in case your thoughts are not organized yet, you can leave a space for it and you can attempt and come back to it later. Always try to, when you're answering the question, have the headings and summary. I have tried to give you an example about phenytoin that I talked to you about. So here I told you how the different 10 heads have to be put in. It ensures that you are writing in sequence, and all the things, they are just going to be adding on to this. When you're talking about pharmacokinetics, you are writing about that this drug is having high plasma protein binding. You are writing about this drug is metabolized by CYP2C9 and 2C19. It causes microsomal enzyme induction. So meaning thereby, you remember that this way you can add up to the drug interactions. Okay, so then you're talking about pharmacokinetics. It is having also zero order kinetics at higher dose. So this could again add on to the drug interaction which is there. You're talking about toxicities. You're talking about ADRs which are there. You're talking about the therapeutic uses. You're talking about, along with that, what is the status for each of this indication. You are talking about the important precautions to be taken. Always support your answer with a diagram or flowchart. But it's very important that when you're using your diagram or a flowchart, it should be which is reflecting what question is being asked. It should not be there you are being asked something else, and because you know one diagram, you would put that diagram over there. Because the examiner would really get annoyed if you're trying to do it like this, because then you will not get credit, rather it will be discredit, because it becomes a very glaring that you, as a student, you do not know what the question is about, and you are trying to just cover up the space. Always underline the key points. They are always a good point so that you can remember, and the teacher, while evaluating the answer, can also check it that all these questions or the important thing which a teacher has in mind for a particular question, they are already answered or mentioned over there. So that was all that how you should try to decode your theory exam.